Greetings from ECS Heart. My name is Hadi Skouri. I am a heart failure specialist and heart transplantation specialist at the American University of Beirut Medical Center. And I will be talking about cardio oncology. Cardio oncology really is a growing field since early this century. And the reason for that, because there are a lot of chemotherapeutic agents that are being used in cancer, which is increasing in prevalence. And these therapeutic agents or chemotherapy, even though they are improving survival in cancer and increasing the rate of survival, even up to more than 15 years, we still have complications or side effects from these medications. A lot of these medications, they have cardiovascular toxicity. One of them is LV dysfunction that will lead to heart failure. But in addition, there are other toxicities, including arrhythmia, hypertension, pericardial disease, pulmonary hypertension, as well as deep venous thrombosis in these patients. So the most important thing, we need to risk stratify these patients before starting chemotherapy to know who are the patients at high risk to develop cardiac toxicities. Second, we need, during treatment, monitor these patients to detect early toxicity. It's very important to detect it early because it will be in the reversible phase. So if it's being treated early, then we can reach success rate in preventing cardiovascular complications and succeeding in completing the chemotherapeutic regimen for increasing survival in these patients. There are a lot of methods being used to detect cardiotoxicity, but the most are echocardiography, cardiac MRI, and some biomarkers, including troponin T, I, and anti-proBNP or brain natriuretic peptides. Depending on the chemotherapeutic agent that is used, we need to choose our diagnostic modalities. So if we use only 2D LV ejection fraction is not enough. And the reason for that is that when the ejection fraction drops, means that the toxicity already happened and it's not reversible anymore. So we need more accurate measurements to detect early toxicity, like deformation methods in echocardiography. The most important is global longitudinal strain that is being used nowadays. So a drop of more than 15% to drop in GLS, it will signify that the patient has a high risk to develop LV dysfunction. At the same time, 3D echo assessment of ejection fraction is better than 2D echo assessment of ejection fraction. Cardiac MRI is used as a second step if there are some problems or in 2D echo or 3D echo acquisition or suspicion of LV toxicity that is not confirmed. In addition, biomarkers, troponin T and I are widely used. So if there is a positive troponin or an increase in troponin, then the patient is at a 5 to 10 fold increased risk of developing LV dysfunction, especially if the troponin is persistently positive on subsequent measurements. As I told you, the cardio oncology field is growing. There are a lot of studies ongoing for diagnosis as well as in treatment of these patients. So whenever we reach stage B LV dysfunction, for say, when we have cardiovascular toxicity, LV dysfunction without any symptoms, we can start treatment as stage B heart failure with ACE inhibitors and beta blockers or ARBs, like the preventive heart failure strategy. Also, there are a lot of publications that will be published soon from the oncology part as guidelines on cardiotoxicity, as well as from the cardiology societies, including position statements on biomarkers and imaging modalities in the cardio oncology field. Thank you.